I want to begin with two patients. Both approach a surgeon asking for an elective alteration of a healthy body. By ordinary standards, both requests may appear extreme. The first patient wants her floating ribs removed, the 10th, the 11th, and 12th, to narrow her waist beyond what diet, exercise, or liposuction could achieve. The bone will not grow back. She understands this. She believes the result will give her the silhouette she wants. The second patient wants cosmetic height surgery. He asks for his healthy leg bones to be surgically cut, stabilized with rods or external devices, and gradually lengthened over time. There is no injury, deformity, or disease requiring the procedure. The aim is to become taller. This too is a major intervention on a healthy body. It is painful, prolonged, risky, and irreversible in its basic result. Yet, it can still be presented as enhancement, aspiration, or self-improvement. Here is what makes the comparison important. Across 3 years of field work, I contacted roughly 100 cosmetic surgery clinics and other professionals working with body modification requests. The pattern was clear. Requests such as rib removal or cosmetic height surgery may, in some contexts, enter the clinical pathway. Other requests, however, are stopped almost immediately. So what makes the difference? It cannot simply be that the request is elective. It cannot simply be that the procedure is invasive. It cannot simply be that healthy tissue is being altered. And it cannot simply be that the patient wants medicine to change the body in a way that ordinary judgment may find extreme. Medicine already does that. The question is why some extreme requests are translated into enhancement, beauty, proportion, confidence, or self-realization, while others are translated immediately into pathology, irrationality, or refusal. That is where body harmony returns. One request is treated as an exaggerated version of an accepted bodily ideal. The other is treated as a violation of what the body is supposed to be. Why? Today, I want to explain what my fieldwork uncovered about that question. Across the interviews, a recurring decision logic began to appear. Surgeons did not present it as a formal system, so I organized the pattern myself into 4 postulates. Taken on their own terms, those postulates could allow a wide range of elective body alterations to be considered. This is Contested Bodies. I'm Leandro Loriga. Welcome to episode 6. Who gets to decide? Welcome back. The first 5 episodes built the conceptual ground, the history of BAID, embodiment, the comparison with gender dysphoria, and the principles of medical ethics. Today, we enter clinical practice. What happens when a patient presents an unusual request to the person who must approve, perform, or refuse it? Somewhere between the bioethics textbook and the consulting room, autonomy begins to change shape. The patient could appear lucid, informed, and consistent, while the request was still treated as self-evidently unacceptable. The stated framework did not fully explain the decision. So I went to the people making comparable decisions in practice. Over 36 months, my fieldwork involved roughly 100 cosmetic surgery clinics, related professionals, and organizations working with bodily modification. I spoke with surgeons, clinical psychologists, psychiatrists, and others involved in assessing such requests. The research took place in person where possible, and otherwise by telephone or email. The semi-structured interviews lasted around 33 minutes on average, although some were shorter and others considerably longer. Interviews were recorded when consent had been obtained and the material was anonymized for analysis. I then coded the transcripts and looked for recurring patterns in how professionals assessed motivation, expectations, risk, bodily proportion, and legitimacy. A decision framework gradually emerged. The participants did not present it as a formal system. I reconstructed it from the reasoning that appeared repeatedly across the interviews. Their decisions did not always follow the clean, autonomy-based model described in bioethics textbooks. Let me show you how it worked. When I brought the interview material together and began comparing how professionals explain their decisions, two concepts emerged. Participants sometimes use this language directly. Elsewhere, the concepts appeared through the standards and assumptions behind their answers. The first is normativity. Here, normativity concerns the patient's reasoning. Why do they want the procedure? Where did the desire come from? What do they expect the operation to change? Does the motivation appear stable and autonomous? Are the expectations realistic? In plain language, normativity asks whether the patient is presenting a coherent and credible case for what they want. The second concept is body harmony. Body harmony concerns the proposed result. Will the body appear balanced? Will its proportions fit together? Will the outcome look natural according to the aesthetic standards used by the surgeon? Normativity evaluates the reasoning behind the request. Body harmony evaluates the bodily form the surgery would produce. In routine cosmetic surgery, these standards often support the same decision. Patient presents a stable reason for requesting a limited change, understands the likely outcome, and seeks a result that remains within familiar ideas of proportion. The unusual cases expose the difference between them. A patient may reason coherently and understand the consequences, while requesting a body that falls outside the surgeon's idea of harmony. That tension becomes decisive in BID. I will begin with normativity because this is where the explicit decision-making logic appeared most clearly. Within it, I identified four recurring combinations of motivation and expectation. I call them the four postulates of cosmetic surgery legitimacy. They provide the structure for what follows. Before we reach the four postulates, we need the basic structure. Across the interviews, two questions appeared repeatedly. The first concerned motivation. Why does the patient want this procedure? Where did the desire come from? Is it their own decision? Or are they responding to pressure from a partner, employer, family member, or social environment? The second concerned expectation. What does the patient believe the surgery will achieve? How do they imagine their body and life afterwards? Do they understand the likely result, the limitations, and the risks? Motivation and expectation became the two main axes of the assessment. The surgeon was trying to decide whether the patient's reasons and anticipated outcome formed a legitimate basis for surgery. In clinical language, was this person an appropriate candidate? When I organized the interview material, four possible combinations emerged. A patient could have a valid motivation, but face unacceptable surgical risk. Their motivation itself could appear invalid. Their motivation could be valid while their expectation remained unrealistic. Or their motivation and expectation could both appear valid and coherent. The first three combinations lead towards refusal. Only the fourth supports approval. They were not presented to me as a formal checklist. They are my reconstruction of the recurring logic professionals used when explaining who should and should not be allowed to proceed. Let us take them one at a time. Postulate 1. The patient's motivation is valid, but the risks of surgery outweigh the expected benefits. The request is refused. A common example from the interviews involved body contouring surgery after major weight loss. The patient may have a clear and understandable reason for wanting the procedure. Large amounts of loose skin can restrict movement, cause discomfort, create hygiene problems, and affect how someone feels about their body. The motivation itself is not in question. The problem is the patient's medical condition. Perhaps the wounds are unlikely to heal properly. There may be a serious risk of infection, heavy bleeding, or deep vein thrombosis, a blood clot that usually forms in the leg and can become life-threatening if it travels to the lungs. In such a case, the possible improvement does not justify the level of risk. This postulate also reveals that the surgeon is assessing more than the patient's welfare. A poor outcome may expose the surgeon to legal claims, professional investigation, damage to their reputation, and consequences for the clinic. Cosmetic surgery also operates within a commercial environment, and several participants spoke openly about that reality. Patient safety remains the central concern. Professional and institutional risk sit beside it. Postulate 1 therefore rejects the procedure without questioning whether the patient genuinely wants it. The motivation may be valid, the expected result may be realistic, and the operation may still be considered too dangerous to perform. Postulate 2. The patient's motivation is considered invalid. The request is refused. This postulate asks whether the desire genuinely belongs to the patient. Imagine someone requesting rhinoplasty because their partner repeatedly criticizes their nose, or because an employer has suggested that their appearance is damaging their career. The patient may appear to be choosing surgery, while the desire has been shaped by pressure, humiliation, fear, or the need to satisfy someone else. The surgeon may then question whether the request expresses the patient's own autonomous choice. The origin of the desire is only the first part of the assessment. 2 further questions appeared repeatedly in the interviews. The first concerned compulsion. Does the patient experience the desire as something they can reflect upon and evaluate? Or does it feel urgent, obsessive, and difficult to resist, closer to a craving that has taken control of the decision? A powerful desire is not automatically compulsive. The concern arises when the person appears unable to step back from it, consider alternatives, or tolerate delay. The second question concerned duration. How long has the patient wanted the procedure? Did the desire appear after a breakup, an upsetting photograph, a period of emotional distress, or a recent encounter with the social media? Or has it remained stable across several years and different circumstances? Duration functions as evidence of stability. A recent and rapidly formed desire attracts suspicion. A long-standing desire is more likely to be treated as considered, persistent, and connected to the person's enduring sense of self. Keep that criterion in mind. People with BD often describe desires that have persisted since childhood or adolescence. Under the surgeon's own reasoning, that duration should strengthen rather than weaken the request. Postulate 3. The patient's motivation is valid, but their expectations are unrealistic. The request is refused. 2 concerns appeared repeatedly in the interviews. The first was body dysmorphic disorder, usually shortened to BDD. BDD is a recognized mental health condition, listed in ICD-11 under code 6B21. A person becomes persistently preoccupied with a perceived flaw in their appearance. The feature may be minor, barely visible, or absent. Some people also develop ideas of reference. They interpret other people's looks, laughter, or conversation as evidence that the supposed flaw has been noticed and judged. People with BDD frequently seek cosmetic procedures. Surgery often fails to resolve the underlying distress. The concern may move to another body part, dissatisfaction may continue after a technically successful operation, and symptoms can worsen in some cases. The surgeon may therefore conclude that the patient expects the procedure to provide something it cannot reliably deliver. A new nose, breast shape, or facial feature may alter the body without ending the preoccupation. One clinical psychologist used the idea of a window of tolerance to explain how intense distress can affect decision. The term is associated with Daniel Siegel, an American psychiatrist known for work on emotional regulation. Picture a window frame. Inside that window, a person can experience distress while still thinking clearly, considering alternatives, and regulating their reactions. Above it, they may become overwhelmed, panicked, or intensely agitated. Below it, they may shut down, withdraw, or feel emotionally numb. The concept does not mean that a person with BDD automatically lacks autonomy. It draws attention to whether distress has become so intense that the person can no longer evaluate the procedure calmly or form realistic expectations. Autonomy in this account can become stronger or weaker depending on the person's emotional state. The second concern involved social media. Surgeons described patients arriving with filtered or heavily edited photographs and asking to resemble an image no human face could reproduce exactly. The motivation may be understandable. The patient wants greater confidence or relief from dissatisfaction. The expected result, however, has been shaped by lighting, filters, image manipulation, careful angles, and repeated exposure to curated bodies. The surgeon is then being asked to create a face or body that exists only on a screen. This connects with the image-based culture discussed in episode 3. Images do more than show us possible bodies. They can establish bodily standards against which ordinary anatomy begins to feel inadequate. Under postulate 3, the patient's desire may genuinely belong to them. The refusal arises because the result they expect cannot realistically be produced, or because surgery is unlikely to resolve the suffering driving the request. Postulate 4. The patient's motivation is valid, and their expectations are realistically achievable. The request may proceed. Only this combination supports approval. Across the interviews, professionals repeatedly looked for what I call a one-to-one correspondence between motivation and expectation. The phrase describes a coherent connection between why the patient wants the procedure and what they expect the operation to achieve. Imagine someone requesting rhinoplasty because they have been distressed for years by a prominent feature. They expect the surgery to alter that feature rather than repair their relationships, transform their career, or solve every dissatisfaction in their life. The motivation and expected outcome correspond. The request appears coherent and the result is attainable. What surprised me was that the motivation did not always need to be common, and the expected result did not always need to be modest. Participants accepted that an unusual motivation could support an unusual outcome when the two made coherent sense together. The request could fall outside ordinary taste and still appear rational within the patient's life. The standard was therefore not would most people want this. It was, does this person understand what they want, why they want it, and what the procedure can realistically deliver. An unusual motivation and an unusual expectation could satisfy postulate 4 when they formed a stable, understandable, and achievable whole. Several surgeons independently offered variation of the same example. A patient works in entertainment, performance, adult film, ballet, or another profession where bodily presentation may carry unusual importance. She requests breast implants far larger than most cosmetic surgeons would consider proportionate. By ordinary aesthetic standards, the result will look exaggerated and visibly artificial. She understands that. It is part of what she wants. The surgeons explained that such a request could still be approved if the patient could give a coherent account of her motivation, understood the physical and professional consequences, and held realistic expectation about what the operation might achieve. The motivation is unusual. The requested result is unusual. Yet the two correspond. The patient believes that a deliberately exaggerated appearance may support her professional image or opportunities within her chosen field. The surgery can produce the bodily change she is requesting, even though it cannot guarantee career success. Within the decision framework described in the interviews, the request can therefore count as legitimate. The standard does not require the patient to want what most people would want. It requires the motivation and expectation to form a coherent, considered, and achievable whole. Pause on what postulate 4 allows. An unusual request can still be legitimate. The patient does not need to want what most people want. The surgeon asks whether the motivation is coherent, whether the expectations are realistic, and whether the patient understands the consequences. In principle, the framework is neutral about the content of the desire. It evaluates how the patient reasons rather than whether the surgeon shares the patient's preferences. That comes close to the account of autonomy developed by Beauchamp and Childress. Freedom from controlling pressure combined with the capacity to understand and choose. That raised the question that guided the rest of my analysis. What happens when a patient with BID enters the same framework? Does the request fail one of the 4 postulates, or does another standard enter the decision? Now apply the 4 postulates to a carefully assessed patient with BID. Postulate 1 asks whether the risks outweigh the expected benefits. Amputation is a major operation with permanent consequences. It carries risks of bleeding, infection, anesthetic complications, phantom pain, rehabilitation difficulties, and reduced physical function. The procedure itself is well established in other medical contexts. For a medically suitable patient, those risks can be described, assessed, and managed. Postulate 1 therefore requires an individual risk-benefit assessment. It does not automatically exclude the patient. Postulate 2 concerns motivation. Many people with BID describe a desire that began in childhood or adolescence and remained stable for decades. The desire is generally not attributed to pressure from a partner, employer, or family member. Its duration should count in the patient's favor under the framework developed from the interviews. Compulsion requires more careful assessment. A long-standing and intense desire is not automatically compulsive. The clinician would need to ask whether the person can reflect upon it, tolerate delay, consider alternatives, and make decisions without being overwhelmed by urgency. A BID patient could satisfy postulate 2, although this cannot be assumed in every case. Postulate 3 concerns expectations. Some people with BID research amputation, prosthetics, rehabilitation, phantom sensations, and the practical realities of disability in considerable detail. Pretending behavior may also give them limited experience of altered movement and assistive devices. That does not mean they know exactly what life after amputation will be like. No patient has complete knowledge of a future surgical outcome. The relevant question is whether their expectations are informed, realistic, and proportionate to what surgery can deliver. A carefully assessed patient could therefore satisfy postulate 3 as well. Under the 4-postulate framework, such a patient may present a persistent and autonomous motivation, an ability to reflect upon the desire, a clear understanding of the risks, and realistic expectation about the outcome. Motivation and expectation may form the one-to-one correspondence that normally supports approval. Yet the BID request is still refused. Why? The answer appears when another standard enters the decision: body harmony. One of the surgeons I interviewed, identified in the research as Michal, was a specialist in cosmetic and reconstructive surgery. He explained how he judged whether a proposed result would look appropriate. I will quote him directly. Proportions should be balanced according to the height, weight, and shape of the lower and upper body parts. The waist and breasts should be well balanced, neither too big nor too small. The nose should correspond to the width of the face, maintaining harmonic proportions. I explain it to patients like this. If a part of your body is screaming for attention, it's disharmonic. After surgery, that part of the body should no longer stand out. Everything should be done proportionally and harmoniously. The idea sounds intuitive. A successful procedure should allow the altered body part to fit with the rest of the body. The result should appear balanced, proportionate, and natural rather than drawing attention to itself. This is what I call body harmony. It concerns the bodily outcome rather than the patient's reasoning. The 4 postulates ask whether the patient understands and coherently explains the request. Body harmony asks whether the body produced by the operation fits the surgeon's idea of proper proportion. The language of body harmony sounds reasonable. Balanced proportions, a result that fits the rest of the body, a feature that stops drawing unwanted attention. In many cosmetic procedures, this standard may protect patients from disproportionate outcomes and help surgeons preserve continuity between the person before and after the operation. Its structure, however, is different from the 4 postulates. The postulates examine how the patient reasons. Body harmony judges the content of the desired result. The operation must produce a body that falls within an accepted range of proportion, balance, and natural appearance. Across the interviews, this language often echoed older aesthetic tradition: symmetry, classical proportion, and, at times, ideas associated with the golden ratio or divine proportion. These standards are sometimes presented through measurements and anatomy. They also carry cultural assumptions about what a proper body should look like. In my analysis, body harmony begins to function as a quiet veto. A request that moves outside the accepted bodily form is more readily classified as potentially harmful. That classification triggers greater scrutiny. The surgeon returns to the patient's motivation. Is the desire compulsive? Is it a symptom? Are the expectations truly realistic? Can someone who wants this outcome be reasoning properly? The patient's autonomy, which the four postulates appeared ready to respect, becomes uncertain again. The performer can still pass through this system. Her requested augmentation may be exaggerated, yet it remains connected to a familiar aesthetic direction. It enlarges a feature already associated with femininity, attractiveness, performance, and sexual display. The result may exceed ordinary proportion, while remaining intelligible within the existing language of bodily enhancement. The BID patient asks for something structurally different. The limb is healthy, functional, and positioned exactly where the conventional body expects it to be. Removing it does not exaggerate an accepted aesthetic feature. It produces a body that falls outside the assumed model of anatomical completeness. The request, therefore, attracts a level of suspicion that the performer's request may escape. A carefully assessed BID patient may satisfy the standards of motivation, duration, reflection, and realistic expectation. Body harmony introduces another question. Is this an outcome medicine is prepared to recognize as a legitimate body? Here is the pattern I found. The four postulates appear content neutral. They ask whether the patient's motivation is autonomous and stable, whether the desire can be reflected upon, whether the expectations are realistic, and whether motivation and expectation form a coherent whole. These are questions about the structure of the patient's reasoning. In principle, they leave open what the patient is allowed to want. The patient is assessed through their understanding, reasoning, freedom from controlling pressure, and capacity to choose. Body harmony adds another layer. Once the desired outcome falls outside the accepted range of natural proportion and anatomical completeness, the request begins to attract greater suspicion. The four postulates are then applied differently. A desire previously recognized as durable may be redescribed as compulsive. A motivation that appeared coherent may be treated as symptomatic. Expectation that seemed informed may suddenly be judged unrealistic. Intense distress may be taken as evidence that the patient has moved outside their window of tolerance and cannot assess the request clearly. The person entering the consultation may satisfy the ordinary requirements of autonomy. The bodily outcome they request then changes how those requirements are interpreted. This is the trap. The framework appears to assess whether the patient can choose. Body harmony influences whether the patient is permitted to count as someone capable of choosing this particular outcome. The patient's autonomy becomes uncertain at the point where their desired body falls outside the form medicine already recognizes as legitimate. Philosophically, autonomy begins to function as a property of the intention rather than of the person. A patient may appear competent, lucid, and capable of reasoning throughout the consultation. They understand the procedure. They appreciate the consequences. They can explain the alternatives. They have held the same desire for decades. Then they request an outcome that the body harmony excludes. The content of the request changes how the patient is judged. Their capacity requires renewed scrutiny. The stable desire becomes a possible symptom. The choice becomes evidence that something may be wrong with the chooser. This was the central pattern that emerged from my fieldwork. The conventional account assumes that autonomy is a capacity belonging to the patient, which the clinician assesses through understanding, reasoning, voluntariness, and stability. My findings suggest that the direction of judgment can reverse. The clinician first encounters the desired outcome. When that outcome conflicts with accepted bodily norms, the patient's autonomy becomes less credible. Autonomy is then granted greater or lesser practical force according to whether the person wants an acceptable body. Most participants did not describe this second layer explicitly. They generally understood themselves as applying reasonable standards of motivation, expectation, risk, and capacity. Body harmony entered through assumptions about natural proportion, completeness, and appropriate bodily form. The result was a reclassification of the patient. A request that fell within accepted bodily norms could express autonomy. A request that crossed those norms could become evidence against autonomy. This reaches beyond BAID. Medicine often faces patients whose choices conflict with professional ideas about health, appearance, function, and a proper human body. In such cases, the clash between medical and societal authority and individual and patient autonomy begins before any final decision is made. It begins with the judgment about which desires are allowed to count as autonomous. There is one more layer. Body harmony is presented as a professional standard, something grounded in surgical training, anatomy, proportion, safety, and aesthetic judgment. Across the interviews, however, the meaning of harmonious, natural, and proportionate was not entirely stable. It varied between professionals. Age, gender, cultural background, personal experience, and, in some cases, political beliefs appear to influence how surgeons imagine an appropriate body. I call this the gap between the professional standard and the subjective standard. The professional standard is the judgment the surgeon is expected to apply. A general, defensible assessment of safety, proportion, function, and likely outcome. The subjective standard is the surgeon's own sense of what looks acceptable, excessive, natural, or wrong. The two can overlap so closely that the boundary becomes difficult to see. A personal or cultural preference can enter the consultation through professional language and begin to influence the clinical decision. For BID, that creates a serious problem. If body harmony contributes to the refusal of amputation, and the meaning of harmony is partly shaped by the surgeon's own assumptions, then the decision cannot be understood as purely technical. The patient is also being judged against a culturally formed image of what a complete and acceptable body should be. Their desired body falls outside that image. The request then attracts greater suspicion, and the patient's autonomy is assessed more harshly. I am not arguing that every refusal of BID amputation is reducible to cultural prejudice. Irreversibility, surgical risk, legal exposure, professional responsibility, and the possible looping effects of diagnosis remain serious considerations. The fieldwork suggests that another influence sits among them, a content-based judgment about which bodily outcomes medicine is prepared to recognize. That judgment draws partly from medical practice and partly from the wider culture in which medicine operates. The clash between authority and autonomy therefore includes another question: whose idea of the proper body is being enforced? The consulting room revealed a two-layer decision process. The first layer is the four-postulate framework. It examines motivation, duration, risk, expectations, and the patient's ability to reason coherently about the requested procedure. The second layer is body harmony. It judges whether the desired result fits accepted ideas of proportion, naturalness, and anatomical completeness. A carefully assessed BAD patient may satisfy the first layer. Their desire may be stable, their reasoning may be coherent, their expectations may be informed. Their understanding of the consequences may be clear. The request still fails because the body they seek falls outside the form medicine is prepared to recognize. At that point, the content of the intention begins to reshape the judgment of the person. Persistence becomes possible pathology. Certainty becomes possible compulsion. An informed choice becomes evidence that capacity requires further examination. This is what I call autonomy as intention. Autonomy carries full force when the patient wants an outcome that medical authority already accepts. It becomes weaker when the desired body crosses professional and cultural boundaries. The central clash of this series is visible here, the clash between medical and societal authority and individual and patient autonomy. The difficulty lies beyond the application of ethical principles. Another standard has entered the decision. It concerns which bodies are acceptable, which desires appear credible, and which patients are allowed to count as autonomous. Until that standard is named and examined, the refusal of beaded amputation will continue to appear more clinically neutral than it is. In episode 7, we turn from judgment to outcome. What happens when body-modifying surgery goes ahead? We will examine risk, regret, post-operative satisfaction, and the limits of informed prediction. The comparison with bariatric surgery will help us ask how medicine handles irreversible procedures when outcomes can never be guaranteed. BD raises the same practical problem. How much uncertainty is acceptable? How should doctors weigh the possibility of regret against the harms of continued refusal? And what would responsible engagement with amputation look like if medicine treated the request as a clinical question rather than closing the door in advance? That is where we go next. Episode 7, Risk and Regret. I'm Leandro Loriga. This has been Contested Bodies. Thank you for listening. I'll see you next time. If you enjoyed this episode, please share it and follow Contested Bodies wherever you listen. Contested Bodies is independently written, produced and hosted by me, Leandro Loriga. The podcast receives no institutional funding or external financial support. This initiative was born from a desire to make invisible lives visible and examine the gray zones of medicine and the human condition. You can support the research, production, and future episodes through the donation link in the description. I'm Leandro Loriga. This has been Contested Bodies. Thank you for listening. I'll see you next time.